I am going to speak about the impact of calcium and the impact of lesion preparation on clinical outcome. As background, we know that possibly cause of poor long-term outcome in the drug-eluting stent era is the asymmetric strut distribution and distance from strut to target cells, overstretching, gaps, or geographic miss. So all related to how you are implanting your stent and which stent you are using. And of course, we all know this basic principle, the bigger is better, that was invented nearly 20 years back, but still valid. I mean, the more you are expanding your stent, the best result will be. So in the last decade, we move into more complex anatomy. That means we have more difficult anatomy to treat, heavy calcification, diffuse disease, left main and bifurcations, total occlusions. So undilatable lesions are more and more present in our daily practice. And suboptimal drug-eluting stents can impact, of course, negatively the clinical outcome. Just to show you that full expandable balloon, as you can see here, doesn't mean that you have a full expanded stent. Even on the delivery, I am speaking about the delivery. You see that here delivery is fully expanded, but after implantation of the stent, you see that there is something hazing here. That means it's not well expanded, and then you have to go with another balloon to expand that. So angiography also, good looking of angiography does not mean good expansion of the stent. Like in this case, you can see that even after 20 atmosphere, 24 atmosphere delivering the stent, you will check after IVUS, and you see that in this point, at this point, the stent is underexpanded. And if you look on angio, it seems a fantastic result. So angio is not sufficient alone to give details about what we are doing. This is a typical aspect of undilatable lesion. And of course, if we knew have something like this, I think it is it's very indicative for the use of some more aggressive debulking, because you have something that it is very hard and very strong to dilate. So how to achieve optimal stent deployment? Pre-dilatation, debulking, lesion preparation, high pressure post-dilatation. But of course, before, you have to characterize your plaque and the disease you are treating with. So I think intravascular imaging, more than angiography, will give you more and more details on what you are doing and how to do it. And the goal is lesion preparation is to facilitate stent delivery, reduce plaque shift, and allow optimal stent expansion, as well as optimal stent deployment and expansion should likely be associated with excellent clinical outcome, at least better clinical outcome. So I think with lesions like this that are very diffusely diseased, very long, calcified, look what happened when you are dilating without knowing anything about the procedure. This was done very long time back, around 20 years back from now. And see, after I was succeeding in dilating the lesion with very high pressures and cutting balloon and so on. And you see, after stenting, you see that both diagonal are at least 5 millimeters away from the main vessel. So I think that we have something here very hard, that means calcification, that pushing even the diagonal outside of the artery, but still having some channel which supplying the flow to both diagonal. And this, fortunately, this patient did not come back for any reason to me. So I don't know what is the outcome of this angioplasty. Yeah, you see here exactly what happened. Again, this is another case done in acute coronary syndrome. the operator thought that this is an intermediate lesion and he can do it just with the primary stenting. He tried primary stenting, and this was the result. He tried again with very hard, non-compliant balloon, very high pressure, 24 atmosphere, still having the same aspect. And of course, you cannot leave a stent like this, because this will be, of course, will have acute thrombosis, of course, or subacute thrombosis. And what we did, we went with rotablation inside the stent, and this is very risky because we're stuck in for some minutes in the stent, and I did very hard work to come out with the rota from the stent. But after all, without rota, we would not be able to enlarge the stent and get with 2 balloons inside the stent and to get optimal result. This is again, I think, when you see something like this, diffuse disease with diffuse calcification, just upfront indication for rotablation and debulking in order to be sure that the result will be optimal. So we have, of course, determinants of suboptimal stent deployment with the understanding, the stent understand that means the ratio is less than 1:1 with the vessel, balloon compliance and pressure deployment, plaque vessel compliance, that means cause of impaired compliance, of course, the fibrosis, the calcium, high plaque burden, or previous stent implantation, as well as lesion characteristics also are important or determinants for suboptimal stent deployment. Of course, we should know also that orthoosseous lesions, often fibrocalcified and undilatable, and particularly in elderly patients, and we are seeing more and more elderly patients. So we should pay attention to all these localization and all these kind of lesion. And of course, intravascular imaging plays an important role in defining the plaque morphology and planning also, or to plan also the appropriate debulking strategy and lesion preparation, as you can see in this case. Long lesion like this require more care and adequate preparation before stenting. And of course, we should know that calcification, severe calcification, are present in at least 20 to 25% of what we are doing every time. And it is related, also associated with advanced age, with other comorbidities like diabetes, like chronic kidney disease. And we have, of course, progressively aging population are increasing and coming more, and we are coming more and more to our cath labs for treatment. So all these factors are increasing our challenges in the cath lab. Clinical implication, of course, impaired stent delivery will decrease the stent expansion and malapposition and stent symmetry. This will be associated with more complication like edge dissection and perforation, increased rates of stent thrombosis and restenosis. That means not a good outcome. And in bifurcation lesion, particularly important stent optimization, which highly impact on long-term outcome, and particularly in distal lift main, this is very important. We all have seen these slides. I mean, restenosis and thrombosis are widely documented to be associated with under expansion of the stent. This is more recent analysis and showing that the association calcium, and that means under expansion of stent will be associated with more target lesion revascularization, more vessel related treated and myocardial infarction related in the same, as well as stent thrombosis you see is more and more present in in calcified lesion treated. And if you look here, this is very, very interesting to show that agreement in estimating the lesion calcification on angio between the operator is weak. That means angio is not the adequate mean to judge how much calcification you have on the vessel. This is another analysis showing again the same, that calcium is associated with poor outcome. I have shown this last time, but I think it is very important. This is what is called PSP. That means lesion inspection, pre-dilatation, stenting, and post-dilatation, in order to have good lesion preparation, good stenting, and good optimization, and this will be associated with the better outcome. And this can be obtained only if you are using intravascular imaging, at least in complex bifurcation or in complex procedures. This is again showing from the same authors, showing that target vessel failure is less when you are using this kind of approach. I mean, pre-dilatation or debulking, stenting, and post-dilatation, as well as less death. You see, we are not speaking about, we are speaking about hard endpoints, and target vessel revascularization is much lower. And we all know that, and we'll hear in the next presentation how we can detect calcification. And you see that the most adequate means are intravascular imaging, and use it when you can use it. This is just to show how it takes really, if you have experience with these devices, I think it takes few minutes in order to prepare your lesion, and you will get, even in difficult and complex lesions like this, to have the optimal expansion of the stent, and this will be paying a more favorable outcome on time. But we should remember that sometime even rotaplator fails. Like in this case, I'll show you that in this case, I was not able to complete rotaplator. I went until this point. I was not proceeding more. And of course, my recommendation is not to insist more and more, because this can produce perforation. Why this? Because you can see the extreme tortuosity of the vessel and totally calcified. At this point, I think the multiple tortuosity will not give a good pushing on the device. And I think it is much better to stop here and to think how you can finish your procedure and safely for the patient. And what I did, I stented this segment. I kept, this is the segment total tortuosity. You see how much is tortuous. And you see, I finished up with something like this. That means I crossed over here, left here without treating, but open, and the patient was coming out safely from the cath lab. So I think this is much more than insisting with the rotaplator to have the complication with the rotaplator as well. This is logarithm. We have more than one algorithm for the treatment of calcified coronary lesions. I think all of us have seen these algorithms, and I think we should follow at least the advices for good lesion preparation in order to have good clinical outcome. So my final remarks that calcified coronary artery bifurcations and non-bifurcation lesions represent a challenge for interventional cardiologists and negatively impact the clinical outcome. The presence of calcification can increase the risk of complication in complex angioplasty. Aggressive lesion preparation facilitates stent delivery, changes vessel wall compliance, and then allows optimal stent expansion. And this will be associated with a better clinical outcome. Thank you very much for your attention.
Sir, it was an excellent talk. We actually, aggressive cardiologists are required for treating the aggressive lesions in calcium. Calcium is actually always creates a lot of complications. Sir, actually one doubt I have. The first case you have shown that you dilated with the balloon and you told that both the diagonals were flowing, sir. If that flow is, do you think it is coming from the dissected part of the LAD, or how the flow is coming, sir, to the diagonals?
Which case you are?
You showed that one balloon dilatation was done very well and the stent was opened in the LAD, but both the diagonals were flowing very well. Diagonal.
That is, the flow was coming beyond the stent.
So how it is coming, sir? Actually, it is from the vessel or the...
From the vessel, because I pushed, I think what happened is that I had some calcium in between the channel providing flow to the diagonal and the main vessel, and was pushed by the balloon and the stent. Or maybe I was subintimal some way and I put my stent subintimal. That is another possibility, but I never moved the wire from the vessel. So, and I was sure that I was in the through lumen. So I mean, it is really very difficult to understand why. What happened there?
But both the diagonals were flowing also.
Yeah, the flow was good. Was TB3 even? Yeah,
that is what.
So at that time I have no IVUS. I would like to see with IVUS what happened, but I had no IVUS at that time. It was 20 years back.
So one more question, sir. The last case you could not take the rota bar down. Yes. Do you take or the guideliner can help us to take the rota bar down, sir?
Yes, I think yes. But in this case, we tried to put a guideliner. Was not going the guideliner because the tortuosity and the fibrotic and calcified tortuosity also vessel. So it was not easy to push that much the guideliner inside. So it doesn't provide that much support for the rota. And I think even if you go with the rota with support like guideliner, I think you should stay really aware about not pushing that much in these cases, because you might perforate the vessel, particularly if it's very, very angled, as I showed you.
Sir, can I make a point here?
Oh, yeah, Shuvanan, please.
Yeah, but basically what I feel that if you use a guideliner or a guidezilla, it is very difficult to push a 1.5 bar through it, because they have a connection between the small part and the rounded part. There, it has got a string and a rounded part, and that junction will not allow you more than 1.25 bars. First of all, is this: it is difficult to go with a 1.5 bar and above through the guideliners.
I think, guideliner cannot accept more than
actually.
I think even 1.5 will have some friction.
7 French guideliner will take the 1.5 bar.
And another point,
guideliner will take the 1.5 bar, I think.
Yeah, another point, your rota wear was in the small vessel, which you left initially, but it has got a big OM which you stented later on. If you can put the, I think what I feel that if we could, place the guide wear, rota wear inside the OM1 branch and OM branch, probably it would have been easier to go to the distal vessel, because the direction was slightly changed.
Absolutely. I mean, I think the direction here was completely like S shape. So from the end of the stent where I have stented, you have to come back and then turn down. And this movement with the rota, if you are pushing more, I mean,
that is true, sir.
You will have perforation.
Absolutely, sir. Absolutely.
Yeah. That is why I stopped there. I mean,
yeah, I thought that if you could change the direction to the OM1, then it could have been a bit better trajectory.
Yeah, actually, I crossed over to the other one with the stent.
Yeah.
No, but actually, Shuvanan sir was willing to take the wire into the circumflex artery.
Yeah,
but
that's
he went
it.
into the OM and finalized.
Yeah. That's it. I thought that it would have been easier to put the wire in the OM1 and then go to the OM1 rather than going to the circumflex.
I think it is not related only to wires, and I think it is related to anatomy and to fibrocalcific composition of the plaque at that point. So it is not easy to cross, and I will not recommend to do every effort to cross it, because that is the time that you will have some complication with rotablator.
Absolutely, sir.
And after this, maybe you can cross, but the bar can stuck in these tortuosity. So I think it is good also sometime to think about safety of patient.
Okay, sir.
Ajay, you told a point that it is actually a 7 French guideline, but 7 French guideline, you require 8 French catheter, right?
Not really, it goes in a 7 French, and we have done rotablation with a 1.5 burr in a 7 French guideliner.
But that should be a guide catheter of 8 French, right?
No, it goes in a 7 French guide.
Also,
it goes in a 7 French guide. Yeah,
it will be so tricky, and it will be rubbing. It will not be that easy to take a 7.
It's not easy to take the guide.
But Ajay, if you just imagine, if you have a 6 French catheter, if you take a 6 French guidezilla, it is not easy. 7 French, it is easy because your trackability of the guideliner also will be a problem.
Right. 7 French would be the ideal for 1.5. Yeah.
Dr. Imad, in one of your patients, you showed a right coronary artery stenting, where after stenting you did a direct primary stenting and the stent did not open, where you did a rotablation. So in today, when you have IVL, in such a case, possibly doing an IVL even post stenting would be the preferred.
Absolutely, yeah. Absolutely, I can agree. I agree with you. Yeah, at that. I mean, with open after stenting, I think you can easily pass with. I passed with cutting balloon there, so I think also with IVL you will reach the lesion and can be open with. Just with lithotripsy, yeah.
IVL, laser is also another choice now.
Yeah, laser also is a choice.
Yeah.
Sir, I have one question to you, sir.
Sure.
14 years back when I was in Turin, I asked you that what is your percentage of rotational atherectomy? You said less than 5%. What is your percentage now?
Yes. Actually, I mean, at that time I was using for undilatable lesions. And that was not more than 3%, maybe 3%. And this was the average of usage of rotablation in Europe, not only in my cath lab. But now I think we have learned something more from intravascular imaging and how to treat and how to debulk lesion and how to get more favorable results by debulking before. And we are using more. That doesn't mean that every time I'm having some calcification, moderate or mild calcification, I'm using rotablator. But when you see with IVUS particularly or OCT that you have a lot of calcium there, even if you can go with balloon stents, rotablate before, prepare your lesion before, and then stent, or IVL associated with rotablation, and whatever is needed to debulk the lesion carefully and to have adequate expansion of your stent. So today I can tell you that we are using rotablator in something like 10% of our procedures.
Actually,
Sir,
that is everywhere in the world.
Sorry, last question. I'm sorry. What is your percentage of post dilatation, high pressure post dilatation after stenting, sir?
That is a very good question. It depends on what is high pressure for you.
It is just like we learned from you that it is high pressure is 20 atmosphere maybe.
20 atmosphere. Okay.
For his
more than that.
28 or 30 is his high pressure.
Yeah.
And
more than 20.
OPN
look.
balloon came, it is 45 is the pressure.
Yeah, it is not, not really.
There are two
necessary
ways
in all
to do it.
cases.
There are two ways to do it. If you go with delivery balloon, then semi-compliant balloon, then you have to undersize a bit your stent and go for high pressure with the delivery system, with the delivery balloon, and then you will reach the one-to-one vessel to stent. If you are using one-to-one stent, then I would advise not to go with semi-compliant, so to dilate until the nominal atmosphere, then go for post-dilatation, particularly if you have calcified lesions or fibrotic lesions or in elderly patient as well. Yeah.
Sir, can I go ahead with my presentation?
Sure.
Yeah. Sure.
Sir, in PCI in calcified LMCA lesion, actually how to manage, that is my question. Why we treat? Because the calcific lesions actually difficult to cross and dilate, difficult to deliver the stents. It requires more, creates more dissection and perforation. The stent under expansion and malapposition is there. Polymer disruption of the stent will be there, incomplete PCI, and it will lead on to more TLF and mortality. So it's severely calcification. Actually, this slide was shown by Dr. Sheiban also. Worst clinical outcome compared to patients without severe calcification. You know what is left main? Left main is anatomically unique. It is actually having an oval and angled ostial shape. Then it has a large and a highly variable diameter, reference diameter of mean diameter of 5 millimeters, and is a curved course and having atherosclerosis usually with a longitudinal diffusion, mainly involving the lateral left main vessel walls and extending to 2 branches. It is a very highly variable angle, and circumflex is often the relevant side branch that determines how tough the LM intervention is. So in a PCI, in a calcified LMCA, the first step is to assess the lesion properly to choose the correct device. So intercoronary imaging is better than angiography in assessing the lesions. It is proven without doubt the IVUS and OCT change the practice of the calcified lesion. So you can see that an angiograph can detect only 40%, but if you go to IVUS and OCT, it detects nearly 80% of the calcium without any difficulty. So you can identify the deep calcium, the superficial calcium, the concentric calcium, the eccentric calcium, and the calcified nodule can be identified with both the devices. With the calcium can be detected much more with the OCT than the IVUS. So the OCT and IVUS scores more than 3 requires calcium modification to induce the calcium fracture. If you go to the OCT score, we tell it is a rule of 5. More than 5 millimeters of thickness, more than 5 millimeters of length, and the calcium arc more than 180 degree. If you go to the IVUS score, the circumferential calcium less than 360 has 0 point. If it is more than 360, 1 point. Large length of calcium, that is, if it is more than 5 millimeters, 1 point. Diameter is more than 3.5 millimeter vessel. Again, it is actually less point, and less than 3.5 it is 1 point. And nodule present is 1 point. If it is more than 3, it requires atherectomy device. So IVUS in LMCA will decide the decision, the strategy, the pre-stenting and the post-stenting. What decide? Decide whether the PCI is required or not. Its strategy to decide between the provision of the 2 stents. Pre-stenting, it tells the stent size and the select the optimum landing zone. And the post-stenting to optimize the final result. The OCT also tells the same situation, and you can have, everybody knows the MLD max system and to understand how is it going. So the why LMCA is more challenging. It has more plaque volume and more severe calcification. It frequently requires a bifurcation PCI. The plaque modification techniques are challenging. A long-term outcome always depends upon the MSH at final MSH. Larger the vessel, the better the outcome. A requirement of mechanical circulatory support. So you can have a lot of complementary things. It's all complementary. It can have an NC balloon. You can have an ultra high pressure balloon like OPNC. You can have a cutting or a scoring balloon. You have a rotational atherectomy and orbital atherectomy, IVL and excimer laser. These are the things which is available for the calcium breakage. So the aggressive balloon dilatation LM calcium is very important to understand. In aorto-ostial lesion, the more extensive plaque modification is needed in order to improve the stent expansion and stent wall apposition. But in aorto-ostial lesion, retrograde dissection is possible from ostium to the ascending aorta. So if we go to the rotational atherectomy in LMCA, is it safe? It's a lot of questions many people can ask. But It is unsafe in only 4 situations. One, you have a lesion angulation is more than 45, a lesion length of more than 25 millimeters, in severe elbow dysfunction, and in severe multivessel or unprotected LMCA with a single surviving coronary artery, it is definitely high risk. And if you go to the procedural success, 95% in lot of data with a high procedural success and a low rate of fatal complication. The problems of the rotational atherectomy in LM calcium, a lack of operator experience. You should not start with LMCA as the first vessel to do a rotational atherectomy. A large mismatch between atherectomy bar and the LM dimension. Dimension will be very high. So that your rotational atherectomy bar should be in 2 or 2.25. 1.75 can do, but you can do a minimal bulking with 1.5. Concerns about the no reflow in a large myocardial territory and a paucity of evidence about its net clinical benefit. So remember, the primary rotational atherectomy point is actually the primary rationale is not to debulk the plaque, but it's only modified. And the rotational atherectomy in LM bifurcation is only the rotor wires should be present so as to avoid cutting the other wires. This on one point. Risk is actually can cause acute closure and loss of vessel to be unwired vessel. Major risk is low flow and coronary perforation. A side branch compromise during rotational atherectomy is a question mark to everybody, but you should understand this point. In more frequently, an NC balloon, actually this semi-compliant or NC balloon can cause more plaque shift rather than with a rotational atherectomy. Rotational atherectomy is a more safer procedure than this one. Then IVL comes. IVL is actually used. I'm not going to the IVL technology. It's a simple technique. It is operator actually, that experience actually not a learning curve is not that much required. Operative in large vessels it can use, allows the presence of 2 wires and a very low risk of no reflow phenomenon. Drawback is actually it can develop prolonged LM occlusion during energy delivery because you use 80 pulses and patient can go into bad shape. A coronary IVL appear to be very safe and effective treatment for undilatable calcified distal LMCA. Open NC, deliverability of the bulky twin layer balloon. A rare complication is the balloon rupture or the shaft rupture. And remember, open NC requires an extra support guide wire, a 0.5 less in for the pre-dilatation and the post-dilatation 1:1 balloon vessel ratio. A percutaneous mechanical support needed or not, but the telling that it is needed in 3 situations. One is a last patent vessel, in unprotected left main coronary, 3 vessel disease with a syntax score more than 33. That was a recommendation in 2016. But you should understand there is a published data telling that it is safe and feasible in most of the patients without mechanical support, even in high-risk percutaneous intervention. Routine unfriendly use of MCS for these populations can be spared. And the data telling the 2021 data also telling this is actually not that required. 98% success without MCS. I will be showing 3 short cases and you can understand that what I have done in 69-year-old patient. This is actually a patient with a double vessel disease. You can see the coronary arteries are not looking like that significant calcium, but we thought actually we just do an angiogram showing LMCA disease and so RCA has significant disease in the osteoproximal. We have an osteoproximal RCA 80% and distal. We have put 2 stents and RCA can be finished very fast. Our discussion is mainly for that. We did a distal reference, length of the lesion, proximal reference, and the plaque characterized by IVUS. We take an IVUS to the LAD to LMCA. In LMCA, we look for the length of the LMCA, diameter of the LMCA, and post osteoproximal part. What we have seen is actually the distal reference is actually a 3.2 millimeter vessel, and there is a maximum stenosis with 80% disease with only 2 millimeter square is the pressure. Proximal LAD is actually 3.5. It's a lot of calcium there. In the mid plaque is actually 95%. Actually, you can see a 2.8 millimeter vessel. But 2.5 millimeter balloon could not cross. So we have planned a rota. But we actually thought that without doing a rota analysis of the circumflex, actually we decided to go for a rota. But you should understand the rota. What we decided to do a rota starting from the circumflex up to the major OM. You can see the rota wire is also backing up because of the difficulty, but I just went up to the OM and this is actually done. We have taken a 1.5 bar with 180,000. You can see this one. I have taken the same bar wire out and I did not change the rota bar I kept on the LMCA and I have taken the same wire back. You can see in the left frame, I have taken the wire back and I rotated the wire and taken into the LED. This is actually my practice, and taken down and just do the burring into the LED also. After burring, I took both wires, fill FC and circumflex. You can understand that I have taken only one wire to do burring both the seat. After the rotor bar, what I have done IVUS into the circumflex to understand whether it's done anything or not. You can see a lot of calcium breaks were there you can see a lot of break in these parts, and post rotor created break, especially at the circumflex ostia. Then we have done a quantum apex balloon of 3x12 and a 3x10 flex term I have used. Actually, we created a excellent opening of the vessel, rota and the post dilatation. After that, what I did is actually we used after post cutting balloon. I have noticed the IVUS again, and I was showing a significant lumen area of 4.82 millimeters square in the post cutting balloon area. Then what we have done is actually we have done a long stent down actually into the circumflex, and there is a balloon. I kept a 2.75 into 12 balloon into the OM part. After that, what we did is actually we have done, and the OM part is dilated. With the dilated part, we have used the same cutting balloon. We have taken this wire out and the cutting balloon in the circumflex. After circumflex, why I did like that? I just wanted to do a mini crush technique in the LMCA part. So what I have done is actually I have done the 3x48 science expedition stent into this OM, keeping the circumflex vessel open, and taken a 3x12 NC balloon across the LMCA. Then what I did is actually I noticed that it is not well covered, so I have taken another 2.75 into 15 millimeter stent into the OM. After that, I have taken a 4x18 LMCA to LED. We have seen the measurement of the LMCA was 4.2 millimeters square in the LMCA with the initial one. Then I've taken a 3.5 into 23 proximal LED stent. So this is actually to be noticed. After that, we have done an IVUS again to understand whether the IVUS is LMCA area is very good. We got 13 millimeters square. This is acceptable, but you can see that when you just look at the distal part of the edge, there are two things we have to look into the IVUS. We will be looking at the IVUS, seeing that there is an edge dissection created, and there is actually a hematoma and dissection. You can see a large hematoma in the distal part. To cover that, I have taken another 2.575 into 12 millimeter stent, and then we have done one more IVUS to understand whether it is closed or not, and the hematoma is well covered. So then we have taken a 5x8 port balloon, recrossed the wire, and 3x12 millimeter balloon, 4x12 and a 3.5, 3x15 at 12 atmosphere with a 5. This is actually the second one. Then we have noticed that there is a malapposition in the circumflex, and so we have to dilate very well. Again, we have to dilate much. We have taken a 4x12 circumflex as 28 atmosphere. We have taken a 3 initially. Now we have taken a 4x12 into circumflex and 3x15 into the LED. And then the circ ostia became with a 4 atmosphere. We got a 6.86, and the area is very good. So this is the final result we got. And we got result in 4 vessels are opened up very well. This is the final result we got. So this actually another patient. This patient had a significant calcified disease. You can see a bifurcation lesion. You can see a bifurcation to the circumflex as well as LED. So the double vessel are good, except that LMCA, both ostia, circ and LED was significant lot of calcium. Advice EVG 1.5 years back, not willing. So we tried to wire this. You can see the anatomy is very tricky anatomy. We have taken a fill FC, not cross. I took an XTR and XTR I crossed. After crossing, I directly taken exchange rota bar because I don't want to take a very wire because this is the toughest of the lesions. So I decided to take a barring only to the circumflex artery, not to the LED first because of the angulation. So this angulation was making me, you can see that the circ actually is like Sheiban's last case. It was an angulated vessel. Just I tried to angulate it, and then so can I take after that what I wanted to do, and I have to do a rota to the LED also. So can we take a rota? So I pre-dilated because I just don't want to lose the circumflex artery and take the wire out. I pre-dilated. After pre-dilatation, then I understood what I have to do is actually I have to do a rota bar into the circumflex. So how I will do a rota bar? Now LED circumflex part is okay, but LED I have to do a rota. I saw the wire is almost crossing. There is a wire bias to the almost proximal part of the circumflex. So I thought that field rep to circumflex, rota wire to the LED. Can I do a rota? So I just kept the rota bar like this. I don't want to take the rota bar into the vas, and from there I did a rota. This is the position of the rota. Then I start a rota 1.5. I could do a rota, and exactly I reached up to the ostial part without even coming back to the circumflex wire. Then I did a 2.5 into 12 millimeter. Ostium of the LED is not well prepared. Then I took a flex storm 3 into 10, initially 14 atmosphere, 10 atmosphere, then I went to 14, but again not opened up very well. This is the situation after that. Then what I did is actually I did an IVAS to understand the proximal LED is 4.7, but even then it is not well prepared. And distal LMCA, you can see 5.1, very calcified osteoproximal LEDs like this. We have taken a 3.5 in the 15, again, the flex storm. I've taken a higher flex storm and 10 atmosphere. Then I've taken a 3.5 into 12 NC balloon at 20 atmosphere. I went up very high pressure. Then I put a stent into the LMCA to LED circumflex. When I took the LED stent, it was not going. So I have taken a with the help of a buddy wire, that's Grand Slam wire I have taken. With the help of the Grand Slam, I took the stent down. So these are 2 wires there. These are all the calcium problems. 2 wires, and with the balloon, I can see the balloon stent is there, a resolute stent actually 3.30, and I have taken a stent across the circumflex 4 into 26. And we have taken a 4.5 into 8 pot after the balloon dilatation. This is the first result we got. Then mid circumflex at 3.5 into 12 balloon, I have dilated in the proximal distal part. Then I did a final pot with a 4.5, 4 into 12 into LED, 3.5 into 12 into circumflex, and 4.5 into 8 into LMCA. So we got a 7.6 LMCA. This very important part actually. After doing this one, you should see that the approximation is very good. We got a 7.6 millimeter square in LED. We got an 8 osteoproximal LEDs 8.4, and we got an LMCA area of 12.8. So we got a reasonably successful, a good result after this case. This is the last patient I just wanted to show. The patient had an angioplasty done 20 years back, nearly 15 years back. The patient came, significant disease. We have done a stenting into the RCA with 2 science expedition of 48 centimeters, 48 millimeter stent, and this was the angiogram. The distal LMCA is 80% disease. Patient had a significant disease. You can be circumflexes occluded. We thought actually circus actually an ISR they thought. Nobody has the details about that patient. We had tried with the multiple wires and no wire was crossing, finally crossed with the miracle wire. And no balloon crossed. When I used a Corsair as the channel dilator, again that is not crossed. Multiple dilatation with 1.5, 2.5, 3 millimeter balloon, lesion could not be opened up, tried a flex storm, not crossed, so planned for imaging. This was the situation. So what we planned is actually we did a pre-stenting, circumflex full run, heavy calcified calcium intimal tear. The point is actually, we just found out that time there is a length of pre-stented area of 14.9 millimeters. It was not fully stented. Osteoproximal part was not fully stented, but I created a lot of dissection. The stenting was not there for the initial 14.9 millimeters. And then the dissection length was nearly 9.5 millimeters. So we can see that the ostium of the circumflex and the distal LMC was severely calcified. You can identify there is a length of the diameter, the depth of the calcium was 1.21. With this calcium depth, you ideally requires a rotablation. And I was afraid because I dilated too much. So then I did an IVAS. IVAS also showing a severe calcium. It's a concentric calcium, more than 180 arc and multiple intimal dissection. So then we did an IVAS into the LED showing the similar picture. IVAS actually much better in the LED compared to circumflex. So we decided to do a rotablation. The bar could cross the stent distally. Rotablation of 1.5 bar. Ostial 14 millimeters was not covered by the stent. That was okay for me. But the distal part was actually stented with the calcium inside. But what we did is actually, we could cross that also with the stent bar. And we could cross it nicely. You can see that I could cross the rota bar through the stent down. Actually, calcified part of the stent also I crossed. Then I did a balloon dilatation, flex storm. Then, as usual, the typing of the stent done. 2 stents used. We got a result 4 into 18 and an overlapping segment is dilated. Final pot with a 5 into 12 millimeter balloon. We got a result like this. This is the result we got. Finally, we have done an OCT. OCT is showing actually excellent stent deposition. We got an area of 15.46 millimeters square. In the LMCA, we got a 6 area only in the circumflex proximal part, not in the ostial part. This is the final result we got in this case. So what I just want to tell you that in a calcified lesion, we have to optimize the disease, optimize the lesion in the LMCA bifurcation. And after doing an imaging should be done in different areas to understand how we have done imaging. And finally, we have to create an apposition of the stent, whether you can use an IVL or a cutting balloon or NC balloon, followed by initially preceded by rotablation is a must in most of the cases. Thank you very much.
Thank you, Prathap. It is fantastic cases. I think you have underlined again that lesion preparation is absolutely essential and the key point for good clinical outcome. It's open for discussion.
Dr. Chen came first. Dr. Chen is there?
Yeah, I'm here.
Okay. Oh, hi.
Yeah, I'm sorry, I'm in another city. Imad knows Shenyang city for Dr. Han's meeting.
I told them, yeah.
He told us, but you can have some discussion because you are coming in, discussion will start.
Yeah, thank you. I think I saw your last 2 cases, which are very, very excellent, very, very challenging. So it seems you used the DK quash for just left main bifurcation, right?
That is, now DK crush is used by 80% of the cardiologists in the country. And by default, if DK is not used, that means people are thinking that there was some problem for them or recrossing some issue. Otherwise, most of the time, their by default choice in India is DK crush. And please, go ahead.
I second that.
I'm sorry.
Yeah.
I'm curious. I'm curiously about the long-term follow-up, at least 1 year follow-up for the last 2 cases.
Both the case actually, that especially the second last case, he is doing extremely well. Actually, no problem after that. Now it is 4 years post follow-up, and he is actually a son and daughter-in-law doctors, so they are on regular follow-up with me, and they are doing extremely well. The other patient is actually I have done in another country, so I just don't know what is the follow-up of the patient.
I see.
Prathap, I have some concern about your use of the same wire crossing from, rota wire crossing from one vessel to another. I think it is not easy. It's not recommended even because you know that many times it's not moving anymore. I mean, this is not to do. It's much better to be sure about what you are doing. And I mean, to move with these wires, you should have really very high experience because no coated wires, you have friction. It is many times after rotablation, it is not moving. You cannot get out from the rotaplator.
I know, sir. Actually, sir, only for that point, I just showed this case. I know that you will be bringing some points out of it.
Yeah. So I think it's much better to use to do it step by step every time. It takes maybe 5 minutes more, but and one wire more, or you can just clean very carefully your wire and go back. This is one. The second, the problem with rotablation in left main, I think that only very tight lesion can be rotablated because of the size of main vessel. So what is your opinion? I mean,
but actually ostium of the LAD, ostium of the circumflex, definitely rota is a very good choice, especially 1.5. When you start with 1.5, we almost go with the 1.75, and 2 rotablation is a rotabar is less available in the country in India, and we have seen people in Japan uses 2 and 2.25, but 1.75 is reasonable because after that we can use either. I always use a cutting balloon or IVL now available, but earlier NC and cutting balloon are regularly used by me basically to make it sure that my lesion preparation is very good. I will never take a stent, sir, without just doing a rotablation and go with the stent. I will never do that. I will prepare the lesion very well. And all these cases I have shown you, I have done imaging after that to understand whether the lesion preparation is adequate. This is a very important message. You can do a lesion preparation very well, either with the NC or a cutting balloon, then only we should go ahead. That is actually a very important message I just wanted to tell the people. And the first thing what you told is exactly correct. I just showed that there are people who are doing and to reduce the time and all, but I personally feel that it is not to be done. So I just want to be coming from that.
Sir, yeah. I have a small question about Prathap's, one of the Prathap's cases. Prathap is slightly more adventurous sometimes, you know, when you place two wires, one in the LCX and another rota wire in the LED, and you do the rota, keeping the wire, this thing. And this is a job which should be done by a very, very experienced person, not like, you know, everybody. I would have gone with either one wire, or I would have put a guideliner or something to protect the wire in the circumflex and go with the rota in the, maybe in the LED.
Now, this is what I just wanted to tell Shuvanan. That is a very valid point. Actually, I just showed both the cases only for discussion purpose. The first one was actually Dr. Sheiban came out with the point that you should not ideally do it. Correct. Second point is, I just wanted to tell you very, very importantly, I have done a balloon dilatation of the circumflex and the distal circumflex, because the patient actually having a less flow there into the circumflex. After that, I could not take the wire out. If I take the wire out, rewiring will be a tough job. And I can tell you that circumflex wiring was taken nearly 20 minutes. Initial, the filtrepsy did not go. Then with XTR, I just gone. After that, again, if I take a wire, if the wire does not go, I was actually having a fear that is the most important thing, made me not to take the wire out. Then I thought that how I will do a burring of the osteoproximal part of the LED. Then I saw that there was a wire bias towards the proximal part of the circumflex. I kept the rota bar there and do. And you told that it will be very difficult to take a guideliner with a wire inside. So the same situation, if you keep a guideliner to the one side, how do you take? This is actually guideliner alone taking it's difficult. So the guideliner with a wire in the other vessel will be very difficult.
Ajay. Two options, sir. What you actually can do, if you have a large enough guide, you can leave a microcatheter on the circumflex wire. Correct. And do rotablation to the LED.
So microcatheter will not cause any problem?
No, it's a soft structure. We've done it twice and it doesn't.
This is actually, Ajay, this is the same situation. Even the wire, people are telling that it will be breaking. But
wire will break because wire is a hard structure. If the rota bar actually crosses the wire, the diamond tipped part, especially the distal part, it will damage the wire and it might shear it off. The microcatheter, if it is protecting the circumflex wire, offers you a little bit of safety. Second thing, you can take a second puncture from the other side and then do it through the guideliner.
This is what I have seen in some of the papers published, and people actually started one more guide catheter. You can take a ping pong catheter, and the ping pong, through the ping pong, you can do kind of the rota. That is also one possibility. But I just think that when I did this case, a microcatheter is one definite possibility, because even I was actually confused whether the microcatheter also can get damaged by the rota bar or not.
So the microcatheter which are non-braided, they are the ones to be used. The braided ones can still get damaged by the burr. But like you elegantly showed, the proximal part of the rota burr does not have the diamond chips. If you're able to push the distal part beyond the ostium circumflex and start the burring there and be very, very careful what you're doing, the chance of damaging becomes less. The presence of the microcatheter will give you additional safety. It can be done. It is a little bit. It can't be done through one guide, but you need a second puncture. It is safer than leaving the wire, because sometimes, you know, the burr comes back a little bit and then you're stuck. The wire is broken. It's gone off into distal circumflex. And then we are stuck with a bigger problem than what we started out with at the beginning. So,
correct.
Actually, you do not have a complete control on where you are rotating. I mean, that means,
absolutely.
Yeah. So it is more recommendable, I mean, not to use it when you have a second wire. However, I mean, if you are in a lesion, you have some dissection, you have to leave the other wire. I think the most appropriate is to go with another guiding catheter and go for protablation for another guiding catheter.
Professor Chen?
Yeah, just one question, Dr. Kumar. Would you prefer high speed or low speed rotor?
What, sir? I did not get.
He wants to know what burr speed you use. You prefer a high speed or a low speed?
Yeah, usually, no, I usually take
thank you.
people take 140 to 160. I do 180,000 square feet, 180,000 RPM is my usual burr speed. But yesterday when I did a rota in one case, 180 also could not do anything. Then 200,000, then I went 220. And then that only burred the, yesterday I did a CTO or LAD. I did crossed retro wire as well as antigrade wire. Both the wires crossed, no devices crossed, including toners. Finally, I just managed to take a rota wire down. I initially burred with 150, then 160, then 180, then 200, then 220. With 220, it crossed. But it is it can create a lot of slow flow in a high speed. But at the same time, if you go very slow with the 10 seconds or 5 seconds, then go again, then go again. That is one way of doing. But ideally, 140 to 160 is written, but my usual speed is 180.
Yeah, actually, very high speed, then you should be very aware about it because you should not go more than a few seconds like this, because otherwise you will have thrombosis by heating.
Yeah. Yes.
So that's a great point, because the higher speed we go, the greater the platelet activation takes place. However much one uses anticoagulation, a little bit of thrombus is going to form even at moderate or low speeds. If you do an imaging with an OCT, I'm going to show it in one of my cases, you can actually see the microthrombi forming. The higher speed you go, the greater the damage to the vessel, the greater the platelet activation. And to answer Dr. Chen's question, for what we do in our lab is we peck and polish at 160. The final polishing run we do at much lower speed, because we've found that we end up with slightly larger luminal areas if you do the final polishing run at 120, 130. So we begin at a higher speed, but the final polishing run is always done at a slow speed. But that's our practice. I know people.
No, Ajay, actually, that should be the policy. That should be the policy for everybody. Your final polishing run to be 140 is the maximum speed to be taken. But initially, people take 160 and 180. But if you go to Japan, they use 200,000 square.
Yeah, I know that. In Japan, they use very high speed. But we have come down to, we have a paper which has been published in Anatolian Journal of Cardiology. And we have shown that once we came down with the speed, our anticoagulation requirement was less, and our hematomas were less, and our MECI was less. So basically, we have come down to 150,000, and for polishing run 140,000. This is our rule.
Yeah, actually, 160 to 180, it's just a good speed to go with. And my recommendation is not to go very quick. I mean, very fast with advancing the wire. You should advance it slowly. Even at high will be more effective.
Slow, soft, rhythmic movement of the rota burr is always ideal.
Exactly. Yeah.
Sir, actually, we can go ahead with the next presentation of Dr. Chen.
Sure.
We have a case in box presentation. Professor Chen, please.
So today I will present a cheap case, but I do not focus on the severe calcified lesion, but only a cheap case. So the patient was 78 years old, a lady. The case was done 3 years ago because patient presented repeated chest pain for 3 years and worsened for 2 days. So risk factors included hypertension and type 2 diabetes. So the clinical diagnosis were non-STEMI and acute pulmonary edema. So from the slides you can see both CANB and T troponin I were positive, and also very high concentration of NT-proBNP. EKG showed extensive ST segment depression. So the left ventricular ejection fraction was only 28. So the patient had very severe reduced left ventricular function. So baseline angiography show also multiple disease in right coronary artery. So most of the severely lesion localized at the middle part of right coronary artery. So from left coronary you can see very diffuse lesion, a bifocal lesion involving LAD and diagonal. Also from the epicaudal, you can see distal left main bifocal lesion. From angiography, you can see mild to moderate calcified lesion from proximal LAD to left main, but no more severe calcified lesion in proximal circumflex. This was a 6 French guiding catheter. So the distal vessel looks like 2.5 to 2.75 diameter. So we calculated the syntax score, which was 40. Also, we calculated the syntax score 2 for PCI was 54.1, and for KBG was 43.8. So it means the patient would have had high rate of mortality after PCI as well KBG. So in general, in the modern era, so there are more multiple choice and also multiple studies demonstrated the comorbidities will worsen the clinical outcome for patients with CHIP. So basically, for this case, the very challenging thing was a reduced left ventricle ejection fraction. So we performed a staged PCI for this patient, studied from right coronary artery, because the middle lesion looks like a very severe disease. So we deploy once a DES 3.5 by 18, and after studying right coronary artery, we measure FFR for PLA and also for right coronary artery, which was negative, so we did not touch the proximal distal lesion at all. So 1 week since the first PCI for right coronary artery, here I provide serial angiographies to show the distribution of lesions involving distal left main, LAD, diagonal. So this was also 6 French guiding catheter from spider view, IO cranial, and also AP cranial. Because of the enlarged left ventricle, so the LAD was not in the middle from AP cranial. It shifted to the LAO cranial. So basically, I provided still imaging to show our strategies for 2 bifocal lesion, LAD and diagonal, and also LAD left main with the circumflex, because patient has very significantly reduced left ventricle ejection fraction with 3 vessel disease. So my strategy was to use DK quash for both LAD and diagonal bifocal lesion, and also LAD left main circumflex bifocal lesion. But the procedure should be supported by impeller. Also, the whole procedure was guided by iOS. So before the procedure, I inserted the impeller 2.5 VA system into the left ventricle. So 2 minutes after installation of impeller 2.5, so the patient hemodynamics recovered to be very, very stable. So I started to use DK quash for LAD and diagonal. I think all my friends are very familiar with DK quash. Today, I don't want to provide very detailed steps about how to use DK quash, but I will provide key information for this studying strategy. So now you can see iOS catheter was inserted into LAD and diagonal respectively. So this is the image show. Sorry. So the computer was very slow. So from different arrows, you can see the baseline LAD and diagonal plaque burden was very, very severely, with very small lumen diameter. So at the bifurcation area, just before the bifurcation area, so the proximal LAD diameter looks like 3.5. So it means a very huge vessel. But I think interesting finding that, because this was 6 French guiding catheter, distal diagonal looks like 2.0 millimeter. But from the iOS, so very distal diameter was diameter the diagonal diameter was 2.2 millimeter, but very, very severe plaque burden at the ostium of diagonal. So the minimal lumen area was around 1.9 millimeter square with a plaque burden 81%. So I think this is a very important finding from IVUS measurement. So you can see I use a long stent in the diagonal and another balloon in the LAD. Immediately after standing, I used another NC balloon to optimize side stent and followed by first balloon quash. So the balloon expanded very well, but it could be very, very small for the proximal ID. So I needed to use second NC balloon to complete the quash side stent. I think this image is very important to tell us how to assess rewiring from proximal cell into the side branch. Both wires were a BMW wire. So after confirmation of proximal rewiring, so here is showing of first kissing balloon inflation 3.0 in RAD and another 2.5 in diagonal. After first kissing and part, so I deploy long stent from middle RAD to the proximal with the leaving of sufficient space for the second stent in the RAD. This is the post-dilation immediate after standing technique followed by part technique. So after part, so we need to rewire side branch again. As you know, for an experienced operator, I think it's not difficult. So here, I like to show one more how to rewire diagonal from proximal cell. I think it will be very useful for our colleagues. So after that, second kissing balloon inflation. And this is the final result after second kissing balloon inflation. And before treating proximal RAD and distal left membrane lesion, I did second part to optimize RAD stent. So now I had time concentrating on the distal left main treatment from epicaudal. You can see obtuse marginal was very, very big. And this is the baseline IVUS measurement for distal left main for both RAD left main and central flex. So we can follow the arrow, red arrow, to see how small of the vessel at the distal bifurcation area. So baseline, in ostial central flex, so minimal lumen area was 3.8 millimeter square. It looks not too bad, but very close to the ostium. So the central flex lumen area less than 2 millimeter square. Also very, very severe plaque burden in the proximal RAD, but no more very severely calcified lesion. With the information from IVUS, I think I was very confident about the treatment of distal left membrane lesion using DK quash. So this is a typical case showing two bifurcated lesions treated by using of two DK quash. So left figure show the side stent from the central flex protruding into the left main, and after standing slightly remove the stent balloon to optimize this central flex. Because at the proximal central flex there was no more side branch, so I don't need to use another NC balloon to optimize side stent. After standing, so as usual, we needed to do balloon quash because the balloon was small for left main, so I have to use another 4.5 NC balloon to complete the quash. After that, rewiring into central flex followed by first casing. And the right figure show the immediate result after casing balloon inflation, because the second balloon was adjusted according to the left diameter. So you can see it's a mild dissection as the proximal RAD. After that, standing RAD to left main from cranial and also from spider view to make sure the full coverage of the ostial left main. So after stenting, this is immediate after stenting already left main. So we need to do multiple port technique to optimize the left main stent. So once again, rewiring single flash from the proximal cell. So it's very useful to use the digital 3 centimeter guide wire, which was not transparent. So it's very useful for us to guide the correct position for rewiring. So we need to find a kissing balloon inflation and find a port using 4.5 non-compliant balloon. So even still there was a distal lesion in some flash, I don't think it's necessary to completely revascularize all the lesion. Particularly the distal cell looks like not too big, but from IWAS, the distal flash diameter was around 2.75. So I think we still need some time to watch the clinical follow-up result after the whole procedure. So this is the final result immediately after procedure using 2 decay quash. Usually, for any patient who underwent impella implantation, immediately after procedure, if the patient hemodynamic was stable, so we will remove the impella immediately after the procedure. So immediately after the procedure, before the removing of impella, we need to recheck IOS to see how the procedure was optimal or not. So from the serial IOS images, you can see finally left main minimal stent area was 15.1 millimeters square, which was big enough to make sure the patient will experience a very good clinical follow-up. Also as the proximal ID, as well as the osteal single flash, so stent area was also sufficient. So at 1 year after the procedure, we perform angiography follow-up. So from the AP caudal and cranial view to show very beautiful results at both LED diagonal bifurcation and distal left main bifurcation area. So by 1 year, so the patient LVEF increased from 28% increased to 38%. And just yesterday, patient reached me again. Now patient was very happy because he had no any chest pain, and also the heart failure has been improved much more. So at 3-year follow-up yesterday, so echo showed the LV ejection fraction increased by 45%. I think this will be very important for a cheap case. Thank you, all my friends. I think I have finished my presentation.
Wonderful case, wonderful.
Thank you.
Oh, thank you.
It's a really fantastic case. I think you showed how you step by step and using the appropriate supports, you can do also very compromised patients with complex interventions. So I think this is very good demonstration. It's open for discussion.
Oh, thank you.
Professor Chen, actually, I have a question. Can we do you told LED diagonal bifurcation and a LMCA bifurcation. Can we take one stent into the diagonal, then you just do a crushing of that part, and a stent into the circumflex, and then crush that part. Then can take a long stent and do a double crush with a single LED stent and one circumflex and one diagonal. Is it a possibility, or is it a nice way of doing?
Yeah, I think Dr. Kumar is so smart. I have used your suggestion for some cases using very long main vessel stent to simultaneously crush the two-side branch. But in China we have too much long DES. The longest DES was 38, so I think it will be very short. So after baseline I was measurement from distal ID to osteal left main will be around 62. So I have to use 2 stents. So I'm sorry. If I have an appropriate case, I will let you know.
Prathap, the other point is that from mid LAD to left main, there is a big mismatch.
Correct, sir. Correct, correct.
So you cannot use small stent for left main.
Right. In my past cases, if diagonal taking from very proximal ID, so it's easily to use one stent in ID left main to do two simultaneous clutch for ID and stent flex. Thank you. Yeah, I have left one message here in our chat because by 10 p.m. I have to move to Professor Han's meeting because this evening meeting was the Cardiovascular Society of China in one north city, in Shenyang. Here is very cold.
But tomorrow you have a big presentation. You should be there for complication sessions.
Yeah, I have prepared. I promise tomorrow I will be online on time.
We will miss you. We'll miss you, brother. So
yeah, thank you.
okay,
Thank you.
Thank you. See you tomorrow.
So actually, sir, we can go to the next presentation by Shuvanan
Yes.
Roy. He will be presenting a case. Shuvanan, Dr. Shuvanan, please.
Yeah. This is my case, calcified left main disease. This is a 76-year-old male patient post-COVID. He had a COVID in 2021 April, and now admitted with unstable angina. He has a hypertension, and as well as he is also having a cholelithiasis. So this is the angiography. This is the ileocaudal shot. This is the areocranial. This is the right coronary. And this is the LV. So he has got a good LV, though hypertrophied, is a good LV. And with a triple vessel disease, severely calcified left main, as well as circumflex and ostium and LAD both. And he has a syntax score calculated, which is 43. And now this gentleman, we did a heart team discussion. He doesn't want surgery at this age. So it was angioplasty and PCI. So with that, can I move to my next slide? Or you need a discussion here? Or anything?
No, we'll discuss at the end because we do have.
Okay,
Yeah.
sir. Now this is the caudal shot, and we can see that there is a very diffuse LCX disease, at least from the beginning and to the end. And also there is a very, very bad mismatch of the LCX disease. And also the LAD is also diseased from the beginning ostium, almost from the ostium to the mid portion, but the distal vessel was fine. So we thought of a rotational atherectomy because we tried with a balloon, even a 2.5 balloon could not pass. So we thought of a rotational atherectomy, and this is a 1.5 rotavar. And as I have already said, our protocol is to go with 1,50,000, and we took a little more time to ablate, and gradually we could move out from the LAD, and then we moved to the LCX. Now, also we did a rotational atherectomy in the LCX. Then we used a scoring balloon. In all cases which are very calcified, we use a scoring balloon, and it's a 2.5 into 10 scoring balloon at very high pressure. And we distally, I put a DES 2.75 into 24 at nominal pressure. Then I moved to the LCX again, ostium, did a scoring balloon again in high pressure. Then we thought of doing a two-stent strategy to the LAD and LCX. We put this is by Nano Crush, as you know, that we take a small balloon in the main branch. This is a 3 into 15 millimeter balloon, and a 3.5 into 18 stent in the LCX ostium. And that LCX ostium, that stent was deployed at 9 atmosphere. You can see that it has opened nicely. And after that, deploying the stent, I pulled the stent balloon. In NanoCrush, we pull the stent balloon across inside the main branch and deploy it in a very high pressure inflation, about a 22 atmosphere. And then we inflate the 3 millimeter NC balloon, which was in the main branch, again in a very high pressure, 22. Then it is our first case with the stent balloon and the NC balloon in the main branch at moderate pressures, that is 12 to 14 atmosphere. Then we put another DES, it is 3.5 into 48, overlapping the first one, and deployed that. Then we did a pot with 4.5 millimeter balloon at 16 atmosphere, crossed to the LCX through the starts, and here we took a drug-eluting balloon because the LCX was so diffusely diseased. I did not, go to the distal part because it was so small. I did I put a small stent in the ostium of the circumflex and did a DEB in the distal part. Then we did a final kissing balloon with NC 3.5 in 12 inside the LED ostium and 3.5 in the LCX ostium at 12 to 14 atmosphere. Then I did a final pot with 4.5 millimeter balloon, and also at the ostium at 16-18 atmosphere, and did an IVAS. And with the IVAS, we have seen that the left main, it is, I could not see the, so I mean, in the left main, it is the areas achieved was very significant, satisfactory. The LED ostium, LED distal was 9.67, and their LED proximal was 10.26, and LMCA was more than 13, and LCX ostium was 8.8. This is the final result. And this is the final result. So it is a very small case, and the patient is doing very well. So the take-home message is the rotational atherectomy is an essential tool for plaque modification and for further procedures, and which makes the further procedure easy and optimum. In a calcified LMCA, the threshold for rotational atherectomy should be low because it should be a very fast and quick job. So it is better to go for LMCA, and we take rotational atherectomy in LMCA cases if the balloon doesn't go or balloon does not open at normal pressures. And in a two-stent strategy for LMCA bifurcation, the side branch stent should not be very long because that can increase the stent thrombosis, and particularly in such DES, long DES platforms, we know that every year we lose some amount of stents for stent thrombosis. So basically we used a DEB to cut short the length of the stent in the side branch, and NanoCrush is a very easy way to perform the bifurcation stenting, and we are doing NanoCrush for the last 10 years and with a significant result, good results. And we have published our data so far in many of the platforms and journals, and that is my take-home message. Thank you very much for patient hearing.
Thank you for this presentation. The case is open for discussion. I'd like I have two concerns about your messages. I think in this left main, circ is not side branch, circ is a main vessel, and you know that. And I think that it is important to have data before recommending using OC depth instead of instead of drug-eluting balloon. I mean, in main vessels, I do not have that much data showing that this will be effective on long term. Second, I am concerned about the nano crash. Actually, it is modified T stenting because you are not crushing the stent, because you are doing also even kissing balloon before putting the kissing balloon between the main vessel and side branch and putting the stent in main vessel. That is, I would say, we have did it from the 90s, like modified T stenting or reverse tap, what I would call the reverse tap. So what is the, how much you, first of all, why nano? What does mean nano? How much you can control protrusion, non-protrusion, how much you are crushing on the stent? So
Sir, basically, we have done the bench test. We have done
bench test doesn't matter. Bench test is another thing. You are seeing the stent. You can do whatever you want. Bench test doesn't mean nothing. I am speaking about in vivo. That means on angio, how much you can protrude with your stent, how you can control that.
Yeah, we'd always take a smaller balloon. If it is a 3.5 millimeters vessel, we take a more than 2.75 millimeter balloon. And so we pull the stent towards the main inflated balloon at nominal pressure. So some part of it will be definitely inside the main branch.
But actually, you are not crushing the stent. Actually, you are doing something like kissing balloon before putting the stent in the main vessel, right?
Yeah.
So maybe. It is, you are not crushing. It's not crush. It is
probably compression. It is, if it is not crush, it could be a compression, or some people say that it is an action.
No, look, I am really good. I am happy really with this approach because it is easy. It is good to. But I mean, adding more and more terms, I mean, nano, mini, DK, and so on, this will be making more confusion around. So I think that it is good. It is very good approach. It is what I'll call modified T stenting or whatever. But I would avoid saying crush, because crush is when you are crushing the stent, when you have 2 layers of stent over the ostium of side branch. This is a crush technique. Otherwise, you should not use crush. Use whatever you want. That means T stenting. But it is okay. It's okay. I'm not. This is my opinion. It is not. It is not against your approach. Anyway, it is good approach.
Shuvanan, I have doubt.
Just a minute, sir, to rebuttal, as a rebuttal to Sir's comments. Initially, I did not give it any name. So I presented this case way back in 2014 in Gulf PCR, where Sir was on the chair and Professor Wins on the chair. And Professor Wins said that it is a nano crush. So it was named nano crush, just like that.
Actually, we have another nano crush in Italy also. You know that.
Yeah.
We have another Rigatelli who's doing another nano crush. So I am not discussing anymore about the.
No, sir. Actually, there was a data published from the US also by DK nano crush by Dr. This one.
Rigatelli, yes, it was published. That Rigatelli was there in it.
Yeah. One question I just want, Shuvanan, actually last you just showed a pot. I was thinking the pot balloon was far away from the carina.
No, you have missed that. I used a 8 millimeter balloon initially placed at the.
Okay. Then
I inflated this.
And I just wanted to tell the crowd who are visiting, seeing this program, just little away from the carina, not that far. Actually, the second balloon inflation is just okay. Any question from Ajay, Swamy or Ajay?
No, I think it's a great technique. It actually simplifies and takes the fear away from the operator of crossing, and that's what we used to be scared earlier.
Actually, Ajay, Sheiban sir was telling that crush is the word. He was actually there is no crush. That is why he was telling the crush. But even though
I agree. You see, the thing is that basically the difference between this and the other crushes is the angle at which the side branch arises is of great importance. The more narrow and the more acute the angle, the more difficult it is to try and land or do a modified T or whatever. Whatever name we give it, whether we call it crush or whatever, the narrower the angle, the more difficult it is to perform this technique accurately and to get a proper coverage of the side branch ostium. The more vertical it is, the closer it becomes to a T. So I agree with the, how do you say, the confusion in the nomenclature. But I feel that if one must get a perfect 100% every time coverage of the side branch ostium, some kind of a crush to protrude the side branch stent at least 3 millimeters into the main branch is probably the way to go forward as far as we are concerned. And you can't argue with the results.
Millimeters are always, millimeters are always difficult to predict. If you think that by you are coming 3 millimeters, it may be 5 millimeters sometimes. So
correct.
Millimeters you cannot assess millimeters from vivo.
No, actually, what is the point is that on angio you cannot be sure that you are covering the ostium even, because on angio many times you think that you are covering, but you are not covering nothing. So that is the point with mini, nano, and so on. So this is the point, that you are not covering sometimes. You are not seeing where you are if you are not guided by IVUS during positioning the stent or by OCT. And this is very difficult to do. I mean, that is the point. I mean, this is. But anyway, I mean, these are discussion around strategies. Our intention is to discuss about calcification more than strategy today.
No, yeah. Arneja, you wanted to make a comment and then go to your presentation.
Yeah.
So, I think one question I have for Dr. Shuvanan is, sometimes like you put this the stent, maybe, and you're crushing it with the undersized balloon you said. You're crushing with a balloon which is slightly smaller than the main vessel.
Yeah, that's it.
So, sometimes if you have some struts coming into the main vessel, we sometimes find that if the crush is not adequate at high pressures with an appropriate balloon, sometimes getting the next device into the main vessel can be troublesome. Have you faced troubles, because you're not doing it with a...
No, Arneja, you actually brought a very important point. This was the same thing actually in the first day of discussion. Professor Chen and Dr. Sheiban actually came out with the point that when you crush, you should crush with an adequate size balloon.
Okay,
exactly.
In fact, actually, if you look at the technique, you will see that we take a stent balloon and we inflate it at very, very high pressure. So the edges of the stents are flared. Now you can, just push the flared stent to some extent so that your, I have never faced any difficulty in putting a long, stent in the main vessel because of the flaring. Actually, it is flared by the stent balloon in a very high pressure.
Maximum you may have to crush or whatever, move the strut away again. But my problem with the angle remains. The closer it is to 90, the more successful the strategy will be. The more acute the angle, the more we are relying on luck to cover the ostium.
No, my experience doesn't say that. Basically, why? And I have seen all my cases in all angles. In narrow angles, the results are more profound and the restenosis is less than 90-degree angles.
Well, can we go to the next presentation? Arneja, please.
Yeah, I think we should.
So now coming back to the calcium part of the main part of our discussion, on the left main and the calcium. So this is a 72-year-old male, diabetic, hypertensive, a known patient of COPD. He has had a bypass some 8 years back, and for the last 1 year was having effort angina. And he presented to us with non-ST elevation MI, raised troponin levels, and patient was in LVF. And echo showed an ejection fraction of around 40%, suggestive of moderate LV dysfunction. He had this angiogram done in Pune about a month back, which showed that the left main is diseased, and the distal left main has a tight stenosis. There is calcification that seems to be extending, into the entire bifurcation complex of the left main. The distal left main, the LED, and the circ appears calcified significantly. And the right coronary artery is more or less normal. The PDA is good. The PLV is being supplied by a graft. And this is a Lima-Rima Y graft, which is a sequential graft, which is filling the PDA a very small OM, and a diagonal. The Lima part of the Lima to LED part is occluded. So when you do multiple sequentials, sometimes you compromise the most important part, that was the Lima to the LED here. So the LED was ischemic. So in this patient, so he effort angina for last 1 year, now ACS. He had an occluded LED graft, and so LED was ischemic, and the native circumflex is not revascularized. It's a distal left main lesion, Medina 1-1 classification with heavy calcification. So obviously the patient needs revascularization. Number 2, he needs a bifurcation stenting. We thought since it's a Medina 1-1-1, we would plan a 2-stent strategy, and he needs some plaque modification. So, when we talk of plaque modification, whether it is just a cutting balloon or a rotablation or IVL, I think today what decides this is imaging. So imaging before the procedure will help you to actually quantify the amount of calcification and then decide which is the most appropriate strategy for this patient. So, and when we talk of imaging, I think as far as calcium is concerned, as Dr. Prathap suggested, OCT scores over IVUS as a modality for identifying the quantum of calcification. So, this is the, angiogram that we did, and we found that the distal left main is diseased. And here you see significant calcium. The ostium of the LED also is diseased. And this is the, OCT being done from left main, from the LED into the left main. And this is what we see on OCT. This is the OCT at this ectatic part of the LED, and as it comes proximally, you see, the lot of calcium, near circumferential calcium in the LED, and as we are coming close to the ostium, you see here there is circumferential calcium into the distal left main. So here you see calcium. Here you see in the ostium part of the LED, you see a heavy thick calcium as it opens into the left main. And in the left main, you see there is a near 360-degree arc of calcium, and the thickness is more than 0.5. It's nearly about 1 millimeter of calcium. So a 360-degree arc of calcium at the ostium of the LED and the distal left main. The length of the calcium is about 14-15 millimeters, and the depth is much more than 0.5. It's around 1 millimeters. So with this, I think when you have a calcium like this, as we discussed, rotablation in left main sometimes can be difficult unless you do it with a 2 or a 2.25 burr. So here we thought IVL would be an appropriate choice, looking into the amount of calcium. And as you know, with IVL, more the calcium, better are the results of IVL. So, with this, which a very familiar way to go ahead with calcium is, you assess calcium with OCT, and then if it is very severe calcification, arc more than 1 in all this, and then it's a deep calcium, you prefer lithotripsy over rotational atherectomy. So to facilitate the IVL balloon, we pre-dilated the circumflex lesion with a 2.5 NC balloon. And as you see, the 2.5 NC balloon really does not open up where there is a tight lesion at the circumflex. But our IVL balloon, we used a 3.5 12 IVL balloon. And this is a new low-profile IVL balloon, which crossed, there was an acute angle there, but it crossed reasonably easily, as you can see, with a little bit of, effort, a little bit of guide coming back. So it passed very easily. And we gave 4 cycles of pulses with a 3.5/12, and it opened up very well. We did the same procedure now into the LED, 3 cycles, And then we did high pressure post dilatation with a 3.5 NC balloon, both in the circumflex and in the LED. And then we, you took this IVL run in the circumflex, from circumflex to, as you see, we find multiple cracks in the calcium, and this is a medial dissection here, and the calcium, multiple disruption of plaques of calcium is seen. And then we stented from left main into the circumflex with a 4/18 DES. And we didn't come right up to the ostium because the ostium OCT, the proximal ostial problem of the left main appeared normal. And then, after that we did a pot, and then I did a distal cross. And, we dilated the LED ostium also at high pressures with an NC balloon. And then we put in a 4/12 expedition into the from left main to the LED with a minimal, this was a tap technique that we used. We wanted to avoid this, getting into the ectatic part. So in that process, I think our stent possibly fell a little short. This is the kissing balloon inflation. And then we did an OCT from the LED to left main. And this OCT, as we are coming from here to the here, you see that there is a large dissection, as you can see here. Dissection at the distal edge of the stent. Possibly, our stent was short. We had pre-dilated this area, but the stent was possibly short. We wanted to avoid this ectatic area, so there was some here. But otherwise, the stent was well opened and well opposed. Then we did a report with a 5O balloon, and we put in another short stent at the distal LED, a 3.5 stent in the LED 8 millimeters. And this was the final picture. You can see a very well open circumflex, a very well open LED ostium, and the left main, And this was the final OCT, which again showed that the proximal LED, we got an area of around 8, and ostial LED, the area was around 12, and the left main area was about 20, and a very well opposed stents all over. So the take-home message is, I think good planning is half of your case done. I always feel imaging before the procedure in a calcified lesion is more important than imaging after the procedure, because when you do an imaging before, it really gives you more insight into what strategy you should be choosing. And more the calcium arc, better are the results of IVL. Thank you.
Thank you for this case. Again, it is another demonstration about how we should proceed in these complex situations, and in the presence of complex anatomy, complex calcification, and so on. I think steps are well respected here. That means imaging before, planning how to do, and then do, and you will get for optimal results. So it's open for discussion. Any question?
Jaspal, actually, why do you choose the stent from the LMCA to circumflex, and you have the same measurement of circ and LED, or equal almost?
So, I think we could have done either way. We could have done either from left main to LED, but possibly the circumflex, there was a more tight lesion at the circumflex ostium. And it was more angulated. I thought, doing from left main to circ was we could have done it either way. I think it was just a choice that we made.
No, but actually, if the circ is more angulated, if you do a DK crush or some other technique, you can put a side branch stent at the circumflex. It will be much easier than putting an LMCA to circ. Actually, you just did a LMCA to circ stent, then LED. And if the reverse, if you are doing a side branch stent at the circumflex and put a stent circumflex, then LMCA to LED crushing, that would have been another easy way of doing.
Yeah, I think we could have done.
My thinking.
Yeah, as you said, we could have chosen any of these strategies, a crush, DK crush, or a mini crush, or even a culotte, because here, both are same size. So, we chose a tap technique, a straightforward, simple technique. So we could have chosen any of them.
But the last comment you made, actually, if you have a concentric calcium and the calcium arc is very large, you should choose IVL. I'm just telling that the more deeper the calcium, then IVL is the choice. If the calcium arc is actually not the point of discussion, that very superficial calcium, the lumen is so much compromised, you have to do a rotablation, then only you can do a IVL. I think the other comments can be accepted. Ajay wanted to tell something, I think.
Same thing, sir.
Actually, I mean, we are complicating more and more our lives in these cases. That means we're adding more and more things to do. I think we should, as every subset of or every device, you should wait for good clinical support to use all these devices for the same target. I mean, if you are debulking with rotaplator and then with high pressure balloon, you will get, and if you go with OCT, then you'll see a fracture of calcium anywhere, like IVTR. So actually, we do not have that much documentation about. So I think that we should wait. What is important is to debulk, to get good expansion with your stent. Whatever you are using is good. We all know that balloon-based devices not always can be used because they will not reach the target even with balloon. So we have to go with rota before and then ballooning after rota. This, of course, should be done. Then I think for IVL, we should wait whether will be adding more benefits for the patient or just like any other balloon.
Here, the distal left main, the MLA, it was about a little more than 2 millimeters. So we thought, unless you are doing it with a 2 or 2.25 millimeter burr, you wouldn't really, ablate the lesions adequately, unless you are lucky with a wire bias or something,
Absolutely.
So that was the reason why we chose IVL in this patient. Otherwise, as we said, we could always choose between the two.
Absolutely.
Yeah.
Yeah.
Ajay, can you go ahead with the presentation, please?
Yeah.
Yes, we can.
While I load my slides, I have 2 points. Number one, I completely agree with Dr. Prathap. If the calcium is deep and thick, IVL does a better job than rotablation. Number two, when the vessel size is large, then also IVL has an advantage over rotablation. I don't think there's any controversy about the quality of the results that you can achieve in a large vessel with very, very thick and deep calcium with IVL as compared to rotablation. It's not just an opinion. I think it will be borne out in trials shortly. I will just start to share my screen. So I'm going to show 2 cases. This is the first. This is a 61-year-old hypertensive with dyslipidemia, chronic stable angina for 2 years, crescendo angina for 2 months, couldn't walk to the bathroom. LV function was a little compromised, but thickness was preserved. He had regional wall motion abnormality in LAD, more than RCA, more than LCX. All the 3 vessels were involved. EF was about 35 to 40%. So this is what we normally see often in our. The second case is a 79-year-old lady with severe COPD, osteoarthritis, limited effort tolerance. A creatinine was about 2.3. It had effort angina for a year and a half, and crescendo angina for 3 months. Had an angiogram a year back and was advised a bypass surgery, refused. Maximal medical management was given to her when she refused surgery, but she continued to remain symptomatic and became practically crippled by her symptoms. But she was still unwilling for any surgery. And this is what her angiogram was like. The right coronary artery was essentially normal, so I haven't shown it for lack of time. Now, this is what we did for our first patient. We first fixed the RCA. This wasn't very difficult. We had to use a long stent and good amount of post dilatation. I'm not going to show it because we're already behind time. Now, what about the left circulation? This is a calcified with a distal left main of 90 degrees, ostial to proximal LAD 90%. A large ramus. The circumflex was small, so we didn't really think it was that significant, but this ramus is extremely large, has got an ostial 90% disease, followed by a plaque, followed by an eccentric tubular 90% stenosis. Now, it's a calcified plaque, so some kind of modification will be required. It's a highly tortuous LED, so you need to be very careful while modifying it. The ramus is a good size vessel. It needs to be addressed, and by definition is a complex lesion, needs to be stented. What about hemodynamic support? And one stent or two stents? Since it was complex, we said we will use two stents at least. And rotablation was our procedure of choice. We were going to do an OCT imaging as well. Tentative two stent DK crush was our plan. We did access the opposite femoral, but we kept the IBP on standby. We didn't put the balloon in the beginning because we had fixed the RC already without too much of a problem. And you can see the difficulty that we had in the wiring when one looks at this view. You can see that the tortuosity and the angle at which the LED arose from the left main made it a little complex. We managed to wire it, but the microcatheter wouldn't go, and we had to dilate with a small balloon before the microcatheter made its way into the distal LED. This is what we normally do. This is an XTR wire. Inside this, a rotablation wire exchange, and this is a 1.5 millimeter burr. Our strategy for burring is threefold. We first divide the vessel into 15 millimeter segments and decide what kind of strategy we're going to use. We peck and then finally polish at low speeds. As I've said, the speed that we use is approximately 160,000 revolutions per minute. And after we peck, then we polish at a low speed of about 120 to 140. And the aim is, as Dr. Prathap had mentioned, to modify the plaque and not completely destroy it. So we also prepared the side branch with angioscalp balloon at high pressure, 2 balloons that we've done. And then after that, whether we have completed our modification or not is going to be decided by the imaging. So that's what we did. We did an OCT in the LED. And we'll try and speed up the runs and show you. We've got multiple cuts in the LED and the small white thrombi that you can see that is caused by the rotablation, which always means there. I'm going to show you still images in the next view. So I think that should be seen. There it is. Our minimal luminal area was 1.12. There were areas of lipid plaque as well, eccentric calcium plaques plus lipid. These are the small white thrombi which are caused by rotablation that we mentioned earlier. The thick plate calcium was thickest about 500 microns, but most of the places where the calcium was thick in the superficial segments, we had got good amount of cuts. We weren't still happy because it was around 500 microns or so at its thickest point. So we thought we'll further modify it, and we used an angioscalp and a high pressure non-compliant balloon for that, along with the cutting balloon. This, since we did not feel confident about landing a long stent in the ramus straight away, we first used a distal stent and then a proximal stent for a DK crush. This is the side branch stent deployment. This is an extra step that we use in our lab after some imaging results. We pull the stent balloon back and do a gentle kiss with the LED balloon, which we have already positioned before we do the final crush. Thereafter, we finally crush it, remove the wire, recross, perform the first kiss. And you can see this is the same balloon position in which the kiss has been performed. There's significant overlap of the proximal circumflex in the AP caudal view. This is an image that we'll see again later, and it's important to appreciate the angiographic differences in the different views so that one positions both the proximal markers in the balloon correctly. This is the preparation of the LED and the long LED stent, which was optimized. The proximal optimization is done here. The circumflex is recrossed. And we crossed the wire into the circumflex, which we thought we had crossed in the optimal position. And you can see, but they're having some difficulty in getting the balloon to follow. Now, we had almost reached our dye limit, so we wanted to be sure. We had one more OCT run that was allowed by the dye for this particular patient. So that's what we did. We did an OCT run before the crush. We opted to do it because we were worried that the left main was a little long, that have we deformed the left main stent. But as it happens, that wasn't the case. We had pretty good expansion in the LED segment of the stent, as well as the left main segment of the stent. That's the circumflex coming up on the side. And we just needed to do a final kiss and a repot. And we were a little more brave after this, and that's what we did. This is the fly-through image showing the same thing. A little bit of malapposition in the distal left main that we would correct later after another pot. Since that malapposition was there, we then did first a repot. This is also an image of the pre and the post to show the luminal area in the LED, the lumen profile comparison. We first again did a repot to correct whatever little malapposition we had seen, recrossed into the circumflex, opened the strut with a small 1.5 millimeter balloon, and then finished our second kiss and report. I've used this image just to show you how much overlap there was in the proximal segment. This is the report. This is our final view. Since we had already reached our dye limit, we didn't do it again, but we had pretty much seen our stent expansions as far as the LED was concerned. We didn't want to do another pot, and we've left this alone, and this patient is doing absolutely fine. This is our second patient, the 79-year-old calcified left main bifurcation with a 90-degree angle between the left main and the LED. And since the RCA was normal, we opted not to use an IBP even in this patient. We decided to use a two-stent strategy DK crush. The choices were T and protrusion, but we are very comfortable and confident about our DK crush, and that's what we did. Again, we had taken a 5 of access with an IBP standby for this particular patient. And this is what we did. I'm just showing you the final views. This is a 1.5 millimeter burr. That is a peck and polish strategy. Thereafter, a cutting balloon was used both at the ostia of the LED as well as the circumflex. You can see that the circumflex cutting balloon also expanded actually quite well without any problem. And we didn't use imaging in the beginning because we had only one run left, and we opted to use it right at the end just in case we needed to do something more. We did have an OP and NC balloon on the shelf in case required. This is the anchor balloon technique that we often use to deliver hardware across calcified segments. You can see that the balloon in the LED has been inflated, and this helps us to deliver the circumflex stent. And once it's positioned in the proximal, with about 4 millimeters or so in the left main, this is deployed. This is our extra step, the half kiss that I spoke about. Then the wire and the balloon from the circumflex are removed. This is crushed in 2 stages. We recross and open the strut, do the first kiss thereafter with appropriately sized balloons, leave a sepal wire, since in this patient we wanted to come right up to the ostium, deployed the LED stent, that's a 3.5, did a pot for the first time, then recrossed beyond that into the circumflex. Did the second kiss at high pressure with appropriately sized balloons, did the final pot. This we always do in 2 parts, one at the distal left main and second at the ostium, and then did an OCT just to be sure that everything is fine. And this is what our OCT run showed: 13.4 at the distal stent edge, 14.55 at the ostial LED, and 15.5 at the left main. This is our final result. This is the before and after images of this particular patient. Thank you for your attention, and I should be glad to answer any questions.
Thank you. Thank you for these 2 cases. Again, very excellent demonstration on techniques, on imaging also, as well as the final results. Fantastic. I think this is what is needed in these patients. Complex patients need to be optimized every time, and you can get optimization by 3 steps as we have discussed today. That means good preparation, good stenting, optimizing, final optimization. Open for discussion.
Yeah, Ajay, actually that your half kiss technique, basically the ostial part of the circumflex to be opened up very well. Probably when you put a stent into the circumflex, if for example it's a 28 stent, you may go up to 14 atmosphere. Your ostium will not be opened up very well. In that case, if you take the balloon back and go up to 18 or 20 or 16 atmosphere, wherever you choose, then that part will be opened up very well. This is a very, very important step. So opening up the ostium, otherwise you may stuck in the final session, actually the final part, then you will be stuck with the optimization. This is actually a very important step.
This is actually our substitute for the 2-step crush. What Dr. Shaolin Chen has shown, that they do a 2-step crush. That means one balloon sized to the main branch and the second balloon sized to the proximal main branch. By doing this step, we try and obviate it. On imaging, we have shown that actually if you do the half kiss, instead of just pulling the circumflex balloon back and going at high pressure, if you actually do a kiss with the LED, you get optimal apposition of the circumflex stent, the part at the carina. Otherwise, if this step is not done, sometimes you end up pushing away the strut from the ostium of the circumflex of the carinal part of the circumflex stent. So you get a beautiful result on your main vessel, but the carinal part of the circumflex stent, that strut actually gets pushed away. And it's like doing a distal cross, and then you end up with some part of the vessel not being covered.
Ajay, actually, you are pushing the stent balloon back
We are
little
pulling
back,
it
right?
back. We are pulling the stent
Pulling
balloon
back.
back, and we are pulling the LED balloon back as well. So
I'm
what this
telling you,
does is,
this is the step by done by that is Rajpal. This fellow is actually Shripal Bangalore, and but he will avoid a crush and the one first kiss recross again. You understand? You
Yeah.
do both together.
I do both. So this is what I do actually is three times the kiss. So I call this the half kiss because this is before the actual kiss the first time. So I kiss
No,
3 times.
basically, it is. We are also doing the same thing. We are pulling the stent, balloon up, and we are dilating with a very high pressure before the kissing. So it causes flaring of the stent, proximal part of the stent in the side branch.
In crushing, when you are, even if you're optimizing the stent on the osteocyte branch, or what we call side branch, after crushing, then this can be moved. It depends on the angle between the vessel. That is the main thing.
Absolutely right. In fact, our first half kiss is most useful in the narrowest of angles. That means the narrower the angle, the more useful it is. The closer it is to 90 degrees, even if you don't do it, your imaging will show you a pretty good coverage of the osteum.
Absolutely, yeah.
The answer of your question that in nano crush, whether it acts in narrow angles, is a similar way it acts in narrow angles.
No, actually, Shuvanan,
what a whole different discussion, sir.
Shuvanan, what he does is actually he pushed the balloon back, pull the balloon back, and then do a first half kiss. He's telling, I can tell one kiss, and then he do a crush.
Exactly.
Then recross, and then so he is actually making 3 crushes and 2 crushes.
Actually, yes. Now when he does the first half kiss, he's clearing the part of the stent which is in the main branch. Then he is crushing on it.
Correct. Absolutely right.
That is the thing, basically.
But before the first the half the case, getting this stent balloon back and going at high pressure should also be done. So you do that followed by that half crush.
Yeah,
absolutely right. Absolutely.
Ajay, I've seen, you have been, both these cases were possibly done with the Judkins catheter.
Correct.
So, complex, although we have come to the ostium of the left main, but, I observed both the complex cases you did with Judkins, even the first case that you showed was a Judkins catheter. I would normally have good support with me rather than, struggle with the Judkins.
No, I think this is a great point. I will always use a Judkins when I'm trying to bring my left main stent back. I feel that it gives you perfect control over where you want to place the ostium. I don't want my guide to go and hit the left main stent repeatedly and deform it. You don't need much support. Once you have done rotablation, you don't need all that much support, especially for left main bifurcations. It's different for a LED D1 or an OM circumflex bifurcation. But for a left main bifurcation, if my stent is coming close to the ostium, I will always use a Judkins.
Good point. I think we should also possibly, well, if you are using rotation, then you really don't need a lot of support.
You don't need much support. You just don't need much support. You just have open. The Judkins catheter for the left main bifurcation. Would you use an extra backup guiding catheter?
No. Okay. What I'm using normally it's EBU. That means any catheter. It is not a big problem for me. I don't feel this problem.
Actually, it is a practice, and if you are cautious and if you, allow the wear to, push your guide catheter out, then it's, if you are aware that
what is important whenever you are coming back, retrieving wire, jail wire, retrieving your delivery balloon, get out from the ostium every time after stenting main vessel, because this will avoid crushing the stent, longitudinal crushing of the stent. This is what is important to do. That means to remember that you have to get out from the ostium with the guiding catheter when you are retrieving jailed wire, or after delivering the stent, or after post-dilating with non-compliant balloons, in order to avoid sucking the balloon inside the main vessel, left main, and then this sometimes will crush the stent. So this is the most important point in doing this procedure.
So in my clumsy and inexpert hands, my longitudinal deformation of the left main is less with the Judkins.
It is not like that actually, Ajay. Actually, you are actually comfortable with the JL catheter.
Yeah, it is the comfort of the operator.
That should not be the choice, and you can actually. I don't actually. I will be a little afraid, and I don't think Sheiban uses Judkins as a catheter because he can use any catheter. This is up to the choice.
No, actually, what we are using just standard normal catheter. That means popular catheters, guiding catheters. Very popular
Actually,
one.
I have seen him using any catheter. You know, he's always with the EBU. In any
EBU, yeah. I'm using more EBU, for example, in my cath lab. So I mean, it depends on what you feel more comfortable or what you are used to.
Sir, actually, it was a wonderful day, and we had a lot of discussions today, and we had an excellent presentation. Tomorrow, we have the complication session where Professor Gambhir will be joining with us with Dr. Shivakumar and Dr. Rajesh Vijayvarjee also joining with us tomorrow. Sir, actually, you can have the concluding remarks and finish.
Well, I think you have already.
No, sir. Actually, I just wanted to tell you about the tomorrow's program. Otherwise, people will.
Okay.
Okay, sir. You can have the concluding
Well, actually, again, I mean, I think we had a fantastic session today. We have seen good cases. We have also agreed about how to approach to these patients. That means complex lesion, complex anatomy, calcification, what is needed to do in these step by step. So I think it was very useful, and very educational. And I hope to have the same tomorrow around complication, because it is another very, very important point in PCA of left main. So I hope to see you all tomorrow again.
So thank you, sir. Thank you.
Goodbye, and have a nice evening.
Bye.